Thanks for having me here to talk to you about a little bit of my research that depend on the pregnant cohort you are recruiting. And I'm an infectious disease epidemiologist. So, my interest currently is on antibiotic use and antimicrobial resistance. And for this particular interest, I'm interested in antibiotic use during pregnancy and the consequence, etc. So, I mean, in perspective, so although we are currently at height of COVID pandemic, we should not despair. As an infectious disease epidemiologist, if you look at long term historically, we have come a long way in fighting infectious disease, right? So the enormous gain made in public health through prevention and treatment of infectious disease has been hailed as a medical miracle. Next slide. So the miracle is largely realized through two important things. One is antibiotics, the other is vaccine, okay? So no medical advance has been acknowledged as the most important than the development of antibiotics and vaccine in 20th century. And antibiotics arguably is the most significant development in history of medicine. The vaccine, the COVID vaccine, will help us to get over this pandemic, and antibiotics will keep modern medicine alive. And without antibiotics, many medical dental procedures that we today taken for granted is just not possible, right? So now, next slide, please. So, but we have a problem. The problem arises is that when the microbes, the bugs, develop resistance to antibiotics arsenal. Okay, so not this yet. Okay, so this is the global crisis. Okay, and CDC, WHO has labeled antibiotic resistance is one of the most urgent global crisis, public health crisis. Now, this problem has been recognized almost 20 years ago by IDSA, Infectious Disease Society American, also alarmed the public about the crisis coming, right? So now, next slide, please. So the crisis actually going to cost human life and cost money, okay? The impact of human life. So as you remember, so as everybody knows that infectious disease cause of death decreased over time in last 1.5 century, right? So the leading cause of death today is non-infectious cause. However, if the trend of antibiotic resistance continued, the picture will be different. So on the left, this graph shows a prediction is that AMR, antimicrobial resistant cause of death today in the world is 700,000. But by time 2050, it will leading to 10 million deaths, which is a bigger cause of death than cancer. Okay, so this is a big problem. And has a great impact on economic, okay? So based on low stress scenario versus high stress scenario, and the cost of antibiotic resistance to the world GDP will be greater than the financial crisis of 2008 and 2009, okay? So just give you basically the scope of this crisis, and this crisis really is a big things because antibiotics is one of the two foundation, vaccine plus the other one, of our arsenal fighting infectious disease. Okay, now next slide. So how antibody resistance happen. So it generally is attributed to overuse, misuse of antibodies leading to resistance, right? In general, we have a bunch of different microbes, and many is sensitive to the antibiotics. And with use of antibiotics, and those sensitive bugs get killed, resistant bugs get survived. And in the same time, some sensitive bugs also develop resistance. So their population increase over time. And more importantly, these resistant bacteria can transfer their resistance to sensitive bacteria. So this is also a very important one, because if resistant gene in a commensal bacteria that cause no harm, but that resistance can potentially transfer to a pathogen, for example, in the gut during co-colonization. So this is a threat that we are facing now. Now, next slide. So why focus on antibody use during pregnancy and in early childhood? Now, in modern society, almost all of us will use antibody at some point in time, right, in life. When and how frequently we use antibodies vary over a person's lifetime. Now, the pregnancy period seems to be a period of concentrate time period where women have high frequent exposure to antibiotics. And next slide. So the estimate is that 90% of women during pregnancy use medication. 80% of all this medication will be antibiotics, okay? And not only during during pregnancy, but also during delivery, right? So using antibiotics. So the use of antibiotics during pregnancy is treat some infectious disease, common like a urinary tract infection, some STD, bacterial vaginosis, etc. Right? And so those are the common infection conditions that require antibiotic treatment. And also there's other condition use that to prevent infection, prevention of preterm birth, for example, prevention of GBS neonatal disease, which is used during delivery, antibiotic, intra-amniotic infection during labor, for example, and when women elect for C-section, antibiotics used. So there's a lot of time antibiotics used during this time period. Now, so what's the consequence? Next slide, please. Might be there. Think about antibiotic exposure during pregnancy. Although antibiotics used for treat infection to prevent infection, could it be leading to infection or other health condition in the offspring? So when we think about this kind of potential risk, is we can think about two ways. One is that think about the side effect of antibody as a chemical toxicity, right? And the toxicity. And although most antibody we choose to use during pregnancy is less toxic, the full story about this chemical toxicity effect we're still not clear, because a lot of clinical trial in just a normal health person don't use pregnancy population for clinical trial. So we don't know. But my thinking is that this toxicity potentially is a less problem. The other problem, really, side effect, is that antibiotics really disrupt the gut microbiome, so the micro community a person have, and the antibiotic exposure in mother during pregnancy impact mother's microbiome, and because baby, the fetus, and newborn get microbes from mother at first. The most important seeding of microbe is from mother. So therefore, baby's microbiome get interrupted, right? And also antibiotic exposure select resistant bacteria. And so you have a resistant pathogen enhanced, enriched, resistant gene enhanced. And because gut microbiome is very important in the development of the newborn and particularly immune system. These lead to consequences such as potential infection later on and particular resistant infection later on, but also other conditions, right? Atopic, asthma, allergy. So there's a lot of study, epidemiology, cohort study looking at antibiotic exposure during pregnancy and a lot of chronic conditions like metabolic condition, obesity, and even autism, okay? So as an infectious disease person, I'm more interested looking at potential infectious outcome, particularly resistant issue. Okay, next slide. So we did a pilot study, mostly using ARG cohort, and we have so our data show that in our ARG pregnant cohort, and 63% use antimicrobial, and you can see the median day on antibiotics was 7 days. It's quite a long time, and we have a woman that even 30 days on antibiotics. So that's a long time, high exposure, and it's almost 30% using anti-GBS prophylaxis antibiotic usage during delivery. Okay, so again, this data confirm high exposure. Next slide. And we also look at basically looking at the risk factor for fecal and our resistant gene pattern in pregnant women and infant. So this is a part of an ARG cohort and part of a baby gut cohort, which Sarah Comstock collected. So this is a small sample size. We only have 36 mother-infant diets, and we're using a kind of a molecular technique to detect resistant gene in the gut microbiome. And next slide. So we show there's a lot of resistant gene in mother and in baby infant, okay? But the infant actually carry more resistant gene compared to mother. And the ARG resistant gene, MGE is a mobile genetic element, is carry resistant gene, but also able to transmit resistant gene from one bacteria to other. So those are important components. So mother, both our population carry a lot of resistant gene, and the baby carry more. Next slide. And so where infant resistant gene come from? And this is a diagram showing basically where infants resistant gene, whether they are shared with the resistant gene in mother or not. You can see it's vary a lot. Okay, for example, the top one, majority of this woman as resistant gene shared by her offspring, but the last one, majority of the gene in baby seems not from mother. So environment, the post-birth exposure also important one. Next slide. And we also look at the different covariable risk factor on the infant resistant pattern, basically resistant gene pattern, and to see whether BMI, smoke status, maternal race, infant factor, sex, delivery mode differ in terms of resistant gene pattern. And then we found maternal race seems to be a significant factor to basically impact on resistant gene pattern in the infant, but not all others. So to next slide. So the one important thing I want to address is, do antibiotic exposure impact resistant gene pattern in baby, right? So we only have questionnaire data on this set of study subject, and we found no significant difference due to antibiotic exposure. However, the problem with questionnaire data is that it's very unreliable. So we have a subset, only 12, have clinical record. And the problem is that the clinical record and questionnaire data, they are not concordant. So they only match 50%. So there's a lot of uncertainty on questionnaire data. So if you look at the clinical record in terms of antibiotic exposure, and we do see that the antibiotic exposure increase, mobile genetic element carrying resistance. Okay, so that's the study we have, pilot study we have done so far. So obviously, when we have much more bigger, better March cohort data, we will explore these further. And last one. Okay.